Yeah. Good Saturday morning to you, everybody, and welcome to HyperFit MD radio show, where age management is always front and center, along with Dr. Charles and Francesca Guglin. I'm Gary Byron. Hey, friends, how are ya?
Good morning. Good morning.
How you doing?
Good.
Yeah, hanging in there?
Yeah.
Got it. How was your week?
Busy.
Yeah, talk to the microphone.
There you go.
Yeah,
There
we're
you go.
Busy.
I can hear you now.
Yeah, we went, fall is here. We went riding last weekend up into northern Connecticut. It was beautiful.
Yeah.
Beautiful. Colors are starting to pop.
Last weekend, if I remember correctly, it was like nice, warm one day and like 15, 16, 17 degrees cooler the next.
Yeah, that was Sunday, and
Sunday
that was the day we
cold.
went riding. We
Right.
froze. Yeah, we were pretty
Especially
cold.
up in Litchfield County.
Right. Yeah.
Yeah, you could. It's really been this past week. Although we've had some warm days in the later part of the week, but I'm starting to really feel fall now.
Yes.
Yep.
You know.
Definitely. You can smell it. The that leaf mold that you smell. It's the first thing that comes to me anyway during fall time. Is that spring and fall are sort of alike weather-wise, but they have a totally different vibe in terms of the way they smell.
Well, everything's
Things like
dying
that.
now,
Yeah.
where everything is blooming.
Right.
In the spring.
Yeah.
People have more allergies in the spring than they do in the fall, though, right?
Yeah, she can't open the windows in our home in the springtime because she can't breathe. And then fall time, I get it. I get allergies in the fall time. So, yeah, definitely.
Well, you have allergies year-round, it seems.
Me, well, I think we maybe have a little bit of mold in our office or something. We'll have to, it's just, yeah, it's that. Plus COVID, when we caught COVID back in 2020, it kind of did a job on my lungs and my whole sinus thing. It's everything about this aspect of my health changed after we caught the virus.
Oh, boy.
Yeah.
So this is an interesting show this morning here. We're going to talk about, I don't know, maybe a lot of men think this is like a taboo topic, but nothing is off limits with as far as this show is concerned. We'll talk about the things that people are uncomfortable talking about.
Absolutely.
That's the allure of this show. It really is. Nothing like it on radio. So let's talk about erectile dysfunction this morning. Let's.
You can't even talk about it without a smile on your face.
I
man.
can't even say the term.
You can't
right?
even say it.
Again, because it's one of those things that a lot of guys don't like to talk about, particularly when you're over a certain age. Although that's a stereotype in and of itself, right? Because
Absolutely.
realistically, there are men that could be in their 20s, 30s, and certainly 40s that could also have erectile dysfunction.
Yes. Yeah.
All right, so let's start with just the very basics. What does the term erectile dysfunction mean?
Well, it's a continuum like everything else in medicine. It starts with some guys with being able to achieve an erection but not being able to finish the act of having sex. Their erection fades kind of halfway through or somewhere during the action phase of having sex. And then it runs the gamut all the way to we see guys in our office who haven't had an erection for years and years. It very definitely is a sort of an ongoing problem that tends to worsen as we get older, or if you continue the lifestyle aspects in terms of the causes of it, it tends to get worse over time too. But very simply, erectile dysfunction is all of the variables that come together to make it so that a man cannot either achieve an erection or maintain an erection.
All right, so I would imagine it's progressive, right? Where you may start off where you can't maintain the erection for the entire duration in which you're engaged in a sexual activity,
Yep.
and then it can progress to the point where you just can't get an erection at all.
Yeah.
So there are warning signs then before you get to that
Sure.
stage.
Sure.
And generally speaking, I'm asking generally speaking because I know that people, some people can get it at an early age.
Mm-hmm.
Generally speaking, when does it start to affect men?
Statistically, and I wrote this down before I came in, let's just talk statistics. 17% of men between the ages of 40 and 49 report problems with erections, 35% between the ages of 50 and 59, 68% between the ages of 60 and 69, and 83% between 70 and 79.
I was thinking 70.
It's as you can guess, it's a burgeoning problem that comes with age. but many health, it's no different than any other health challenges that tend to get worse with age. So
Yeah, but this no, I didn't mean to interrupt you.
No,
but,
go
but
ahead.
This hits close to home though for a lot of men. You know, for a lot of men who want to maintain their masculinity in life for as long as they possibly can.
Yeah, it's where we live. They say we think about it every 7 seconds or so.
7 seconds. Who can go 7 seconds?
I know.
was thinking more like 3.
Yeah.
7 seconds.
Well, there's food too.
That's the other. So it's prevalent. In other words, what you're saying is that it's quite prevalent. Then.
Yeah, it is quite prevalent, and very much lifestyle related. Very much there's hereditary issues involved in that, in as much as there are hereditary issues involved in diseases that can be part of the spectrum of erectile dysfunction also.
But there's got to be a lot of more environmental, portions to this, outside forces that affect.
The main outside force that affects it is relationship issues. Let's not discount the fact that relationship issues can play a large role in sexual function in general, and erectile dysfunction also. So yeah, but I know what you're talking about in terms of environmental stuff. There's lots of toxins out there, lots of hormones that are out there. A phytohormone is a molecule that you find in nature that mimics hormonal action. So there are environmental factors involved. Definitely.
Other causes as well?
That's kind of a broad spectrum question. Yeah, there's lots of causes.
I mean, you mentioned hereditary. We talked environmental. We talked, but what else would cause someone to?
Okay, metabolic syndrome. Let's talk about the 40-year-old guy who has a 42-inch waist cantilevered over a 36-inch belt. Okay, that guy is carrying a lot of belly fat. He already has insulin resistance. He probably has hypertension and worsening cardiovascular disease. That guy is going to have issues with erectile dysfunction earlier than the man who takes care of himself, let's say, who is in better shape, that kind of thing. Diabetes. Diabetics, adult onset diabetics, tend to start having issues with erectile dysfunction long before they would if they didn't have adult onset diabetes, especially diabetes that's not under control. So there are disease issues that are involved because this is very much a vascular event. It has to do with delivering blood supply to the penis on demand. And so anything that affects your vascular system is going to affect your ability to have erections. So yeah, the causes are multifactorial and frequently have to do with lifestyle issues in as much as lifestyle issues lead to disease down the road.
Is it at all temporary, even if you're not prescribing medication?
Sure. What do you mean by temporary?
All right. Stress. If someone has a high pressure career, or
Big deal.
they
Yeah,
are,
sure.
or they're someone's working, even if it's not even if you don't have a pressured career like a police officer or a doctor, or if someone's working on a project, temporary project in work at work.
Yep.
For a couple of months, they're working on a big project and they've got a deadline and they're behind and they're stressed. And could that cause
That's a great question.
temporary
because,
erectile dysfunction?
Yes, that's a great question because the short answer is yes. During the workup of this, when I'm talking to somebody, it's one of the things that we ask about in a lot of detail is what their stress level is. Because look at, an airline pilot and the guy who folds clothes at Target perceive their lives as being equally as stressful. You mentioned police officers, but by the same token, a person who's under relationship stress or they've just lost a loved one, something like that, all of these things can cause issues with this. And it can be temporary, very definitely can be temporary. If you manage the stress, you can manage the erectile dysfunction if that's the source.
So then would the treatment for somebody who has erectile dysfunction on a temporary basis be the same as the treatment for somebody who has got chronic erectile dysfunction?
Not necessarily. I mean, if it's stress related, then you want to help them with their stress. Teach them mindfulness training. Talk to them about things like meditation, things like that. Talk to them about managing whatever it is that's stressing them, and reassure them that when whatever this stress, this loss of a loved one, or this transient issue with their job, so on and so forth, goes away, it's likely that their dysfunction is going to go away also. On the other end of the spectrum, if you have a person who, through lifestyle issues, is unhealthy, if you can help them restore their health, you can help them restore their ability to have erections also.
Okay. How do you evaluate a patient that comes into you with the problem of erectile dysfunction? I would imagine, is it awkward? Well, maybe answer the question first, and then maybe I'm getting ahead of myself. Because as I'm asking you this question, I'm actually envisioning. Hey, doc, I've got this problem with erectile dysfunction, and then you perform whatever tests or you perform an evaluation, and it's humiliating, or embarrassing. Maybe is a better term.
Yeah.
But why don't you maybe answer the question first, and then.
Yeah. It's Francesca's talking about a worksheet that they fill out when they come into the office that gives us an idea of where they are in that spectrum. Okay, it's called a SHIM score. But the first step is to sit down and talk about it. Our practice is a very sort of relaxing environment. People, I've never had anybody sit down and say, well, I can't really talk about this. I mean, by the time they get to a chair in my office, they've decided that they're going to do something about it, okay? So they've already made that decision. They've already talked to a woman on the phone about it, okay, to make the appointment, that kind of stuff. And so the first step is really just sitting down and having a conversation about their life, what's going on, the medicines that they're on, huge deal. Medication is a big problem with this. What they do in the way of exercise. Ryan and I were talking about this before. Cyclists have problems with erectile dysfunction because they sit on their pudendal nerves.
Well, okay, so he mentioned runners, but while Ryan, by the way, folks, is the producer of the show, really runs our board and keeps us on good time here, and produces my morning show Monday through Friday. But he had mentioned runners, and as soon as he mentioned runners, I was thinking cyclists. Yeah. But then I was thinking maybe I'm confusing that with testicular cancer because I'm always hearing that cyclists. Lance Armstrong, for example, Tour de Force had testicular cancer, unless that's, I don't know, an anomaly or that's just here and there. But I always associated those two together. But going back to what Ryan brought up with a runner, people who run constantly, they're always running marathons or whatnot, that could cause erectile dysfunction, or cycling can cause.
Well, cycling is more of an anatomic thing because they're sitting on their pudendal nerves and pudendal vessels. If they're the average person who cycles has not been fitted for the bike that they're riding. And if you're doing 3-4 hours a day, and I was telling Ryan personally, I was a 100-mile-a-week guy for years and years. And after I realized that getting off the bike, my entire perineum and all my junk was numb, that I said, okay, I gotta stop this. I got fitted for a bike, which made things a lot better. But now when I cycle, I do half an hour at a pop. I do high-intensity interval cycling. And I'm standing up most of the time but that's an anatomic thing. With runners, it's a stress issue, especially these guys who run marathons and stuff like that. It's a stress issue. It's an issue with body fat content, stuff like that. It's again, every aspect of this is multifactorial. You have to sort it out. So, it's like untying a knot.
So going back to this evaluation of a patient who comes to you with this problem, I mean, okay, so it's a really calming and soothing environment. But
so we start with a conversation,
okay,
and then we do blood work because frequently it's a hormonal issue. Okay, the conversation has to do with their history. If a guy, I have a good-sized subset of patients in my practice who abused anabolic steroids. Like a lot of these guys are ex-football players in high school and college and stuff like that. Those guys have big problems with erectile dysfunction, even if they're not using steroids anymore. Blood work, you really need to look at the blood work very closely, time the blood work appropriately, and then take a look at that because frequently hormonal issues can contribute to this as well. Get a look from a physical exam standpoint whether or not they have peripheral vascular disease. If a man has no pulses in his foot, for instance, let's say a diabetic who typically one of the first things that that problems adult onset diabetes is peripheral vascular disease. They tend to lose microvasculature in their soft tissues. So if you can't feel a pulse, let's say below the knee in their leg, you know they have vascular issues, and that's likely to be at least a contributing factor in their erectile dysfunction. So the workup, plays a huge role. A lot of practices do ultrasound of the penis to assess blood flow. I don't do that because I think a lot of that has to do with theater, quite frankly. We already know what the issue is. I mean, I have an ultrasound machine, but as far as I'm concerned, there's really no point in assessing penile blood flow by ultrasound because, by definition, if a man is having issues with erectile dysfunction, he's got vascular issues. So a lot of practices do ultrasounds. I don't do those. But a lot of it has to do also in terms of history, the medications that they're on, because so many medications lead to erectile dysfunction.
That was my next. There's going to be two things. Number one is your history.
Yeah.
If it's hereditary, I think you mentioned at the beginning of the show that it could be. But I mean, somebody, you're going to ask your dad, "Hey, Dad, did you suffer from do you suffer from erectile dysfunction?" I mean, that's a weird, awkward kind of conversation to have with your. If you have a dad who's still living, or even know who your dad is, what if you're adopted? And I mean, there's so many different variables there. The other,
if he says no, you only have one person to blame.
Well, I see your nose growing, Dad. I mean, are you lying to me? But the medications that you're on too. So could some of the side effects on medications be erectile dysfunction?
Oh, yeah, absolutely. And many antihypertensives lead to erectile dysfunction. Sedatives, a lot of people take Klonopin for sleep, that kind of thing. Benzodiazepines, THC, marijuana. Marijuana is a notorious killer of erections. So there's lots of them. The categories are endless, really.
Folks, you are listening to HyperFit MD, where age management is always front and center, along with Dr. Charles and Francesca Guglin. I'm Gary Byron. If any of this sounds like, let's say it hits home to you, and maybe you're thinking to yourself as you're driving down the road with somebody in the passenger seat, I don't know, do I want to write this down? Remember this. Remember this website, folks. It's easy. You don't even have to write this down because I don't want to embarrass you. HyperFitMD.com. Doesn't get any easier than that. HyperFitMD.com. And you can call to make an appointment at 203-890-9777. At the end of the show, I'll repeat those points of contact for you. So what are some of the treatments that are available for this? You touched upon something a little while ago, and maybe I threw you off track with another question, but.
Well, the first step, the first treatment, if you will, is trying to assess the cause, which we've already spoken about. If it's a hormonal, for instance, if a man comes in and he's post-andropause, if he's in his 60s and his testosterone levels are low and his thyroid's a little bit tired, first step is restoring his hormonal balance and optimizing hormones. They're very definitely the first step. Now, testosterone and thyroid are not treatments for erectile dysfunction, but they set the stage for success in treatment. Although frequently, optimizing a man's testosterone levels will get rid of erectile dysfunction. Once we do that, and if they're still having issues, we'll move to kind of more of a procedural approach. One of the things that we do is what's called shockwave therapy, low-intensity shockwave therapy, which it's based on the principle that you have to injure a tissue to get new blood supply into it. So shockwave therapy, think about, there's really only one analogy I can think of with this particular machine. It's like a tiny little jackhammer is what it's like, okay? In the sense that patient comes in, he puts a little numbing cream on his penis to numb it up, and then we apply this machine, and basically it's shaped like the handpiece is shaped like a pistol, and the barrel has a ceramic ball in it that impacts a ceramic tip at about 17 cycles per second. And you apply that to the erectile tissue of the penis. There's no bruising, there's no bleeding or anything like that. But it is a minor shock wave that transits the penile tissue that starts the first wave of healing, which is inflammation. The first phase of healing is inflammation. We talked about this when we talked about regenerative therapy a couple of weeks ago.
Right, I remember that.
Phase 2 is fibroblast, and phase 1 is a platelet aggregation in that site, so that they send all sorts of chemical messengers to your immune system, sends all sorts of cells down there, stem cells, fibroblasts, all the stuff that starts through the stages of healing. And the third stage of healing is always neovascularization or new blood supply, which is the end stage of this treatment. So it is a healing treatment. The protocol is like a 6-week protocol. It's 6 treatments altogether. And then you wait 4 to 6 weeks because the final results don't come for a few weeks.
But when it comes, is it permanent?
The effects typically last for a year to 18 months.
And then you have to restart that cycle of procedure
maybe not,
all over
maybe
again.
a few a la carte treatments, that kind of thing. Yeah.
Okay.
Yeah. We have a lot of guys come in for a treatment here and there. Yeah, and another thing that we use, which it's kind of not so much 6 of one, half and does the other. They're kind of they are complementary treatments, but the end stage is the same. It's a trade name called a P shot. I'm not supposed to use the trade name, but that's what everybody knows it as. Where we take, and again, this is a regenerative therapy, like we talked about a couple of weeks ago. We take 60 cc's of your blood, process it, and wind up with about 7 cc's of pure platelets, and then again numb up the penis and inject those platelets directly into the erectile tissue. And again, those platelets start the healing cascade that winds up over time with new blood supply to the penis. Now, during these protocols, the patient also uses what's called a vacuum pump, or what is known as a penis pump, because guys who have not had erections, if you don't use it, you lose it. And guys who have not had erections for a couple of years, they lose the length and the girth of their penis, and this brings it back. So we want to give themselves an erection 2 or 3 times a day. Just pump it up for 5-10 minutes, and then just let it go, because that does 2 things. It brings back the length of the girth of the penis, number 1, and number 2, it reestablishes that neurovascular connection, because this is very much brain-related, the ability to achieve an erection. Anybody who has problems with this knows that at some point it got into their head and it became a real problem. And so helping somebody achieve erection on a routine basis kind of reestablishes that neurovascular connection. And we also want them to take a nitric oxide supplement. Nitric oxide is what your blood vessels secrete. If you're working out and you're feeling that burn, your blood vessels secrete what's called nitric oxide, which dilates the blood vessels. And so these nitric oxide supplements, it's not a pharmaceutical, it's just a supplement, help with vasodilatation or helping to open up those blood vessels a little bit also. So the treatment is multifactorial. If you go to a urologist, he'll give you what's called Trimix, which is a prostaglandin inhibitor and a vasodilator that you inject directly into your penis, and about 15 minutes later you get an erection that lasts for about an hour. I don't prescribe that. If patients want that, I just send them to my local urologist.
Sounds like there's more than one procedure here to help with patients. I mean,
Sure.
It sounds like they've got options. How do you determine which option is best suited for each individual patient then?
Good question. I typically we try to treat it hormonally, make sure that everything, before we even talk about procedural approaches to this, we want to make sure that the person, from a metabolic standpoint, is intact and functioning on all 8 cylinders. And once we get them there, then we'll talk about procedural treatments. Some guys don't even want to talk about that, and I'll say, okay, well, if you want to go for treatments, let's do it. I try to start with shockwave therapy. I think that probably it's a good segue to the P shot. If the shockwave therapy doesn't work, we'll typically follow it up with a P shot.
Okay. Yeah. What's the success rate then for each of these treatments that you're offering?
Totally depends on the clay that you're working with. With a guy who's had, for instance, prostate surgery for prostate cancer, the success rate is not great, and I tell them that. For guys who have adult onset diabetes, it depends on whether or not they want to actively control their blood sugar. There's a lot of people with adult onset diabetes that just don't pay too much attention to it. They take their pills and they go their way. Sometimes we'll even get somebody on continuous glucose monitoring to make sure that their glucose levels are nice and steady during the day. So those guys, the results are not quite as good as somebody who's fairly healthy, not much in the way of cardiovascular disease, is young and starting to have problems, that kind of thing, those guys, the success rates are pretty good. I would say up to upwards of 70%.
Oh, wow.
Yeah.
Is it inevitable? Is this going to happen to every individual male?
Yeah, it's going to happen sometime. I mean, I have some guys in the practice in their 60s for whom this is not a problem yet,
Yeah.
But those guys have been paying attention. Those guys are super healthy. They're on hormone replacement therapy. Those guys are pretty much optimized to the max, and those guys are not having problems. But
Yet.
pretty much happens to everybody.
Yet.
His daily sales.
Well, there's you mentioned Cialis, and of course,
right.
the,
Thank you.
the
I
little
didn't
blue
even
pill Viagra. I mean, those are all part of.
Well, I didn't. That's an important thing to mention, because a lot of guys are happy if we can get them to a point where Cialis works for them. Okay, if we can get a lot of these guys, if we can get them to a point where Viagra will work for them, they're super happy about the results. Okay, so these medications are definitely part of the plan. I completely neglected to mention.
I've got to wrap this show up. What is in 30 seconds or less? What do you think? What is the difference between Cialis and Viagra?
The main difference, they basically operate through the same mechanism of action. Cialis is a longer-acting medication. It has a serum half-life of about 18 hours, so it hangs in there for about 30 hours altogether. Viagra is good for about 4 hours. It's probably works. Most of the guys that in the practice will say that Viagra works better for them, but I don't think they're taking Cialis the right way. I tend to prescribe Cialis as a daily medication, as if it was a heart medication, as opposed to just taking it episodically.
Folks, if you've got any questions that you would like to ask Dr. Charles Guglin, you can certainly email him at cguglinmd, CGUGLINMD, at HyperFitMD.com. You can check him out down in Milford at 88 Noble Avenue, Suite 105. And as I said earlier, have a poke around his website. It'll probably answer some questions. Of course, it may spur some other ones in you, which always seems to occur. At HyperFitMD.com, HyperFitMD.com. That always happens to me. I'm like, oh, I got the answer to that question, but what's this? It just spawns other questions. And that prompts the phone call to schedule the appointment, which is all the more reason why I'm going to give you his number. Write this phone number down, my friends. 203-890-9777. Once again, 203-890-9777. For Dr. Charles and Francesca Guglin, I'm Gary Byron. Thank you so much for listening to HyperFit MD Radio Show. Until next week, have a good one, everybody. So long.